I was saying earlier, I think it's been incredibly helpful. When Mike Padmore and I were discussing how to do this, we're going to try and keep our segments relatively short so that you will have relatively more time for questions of the stuff that you want to talk about. But I'm going to start where Mary Jane Molnar left off in the last Zoom meeting, and I'm really glad to have followed her because she talked about the budget. And actually, if you're talking about health policy, the biggest health policy bill is the budget bill and the trailer bill that goes with it. Because, you know, a lot of our policy is dictated by what we are willing to fund. And that doesn't come through my committee, so I may not touch as much on that to begin with. But Health and Human Services is 43% of the New Hampshire state budget. So it's a huge amount of stuff. And so the budget bill and the trailer bill are as much policy as my committee. The rest of health policy is divided between my committee, which is Health, Human Services, and Elderly Affairs, Commerce, which deals with the insurance aspects, Children and Family Law, which takes a more specialized look at the needs of young children and adolescents. And, you know, there may be a few other overlaps, but those are the major ones. So what I wanted to start out with was a little bit of an idea, as Mary Jane told you, about how the budget is set, about our process, because I know in my district, Republicans are already putting out this message that Democrats all have to walk in lockstep behind their leader in Manchester. And if I ever see Democrats walk in lockstep about anything, I'll know that the end of the world is near, but, you know, convincing other people of that is a thing. So here's how we set our priorities this last term. In each policy committee, the Democrats on the committee had a caucus, and the caucus came up with the policy areas that they wanted to put as our first priorities for that committee. Those policy objectives were then shared with the whole caucus, and the whole caucus got to say, and of all of these, some of our first priorities are, and access to healthcare was one of those, along with education and some others. So that's how our priorities are set. They come from the actual elected individuals, and in our caucus, they come from the bottom up. So I just wanted to put that out there if you're being told otherwise. So the four main priorities that we came up with in my committee were, first, access to healthcare in terms of availability and affordability, and that is everything from really micro bits of how you get services to people, all the way through the grand questions of how we finance healthcare, but those have to be done mostly on a non-state level. So access and availability and affordability was item number one. Item number two was mental health and addiction and recovery. Item number three was the healthcare workforce, because we need healthcare workers at every single level of training, from ward assistants and LNAs on one end of the training scale all the way up through psychiatrists. We don't have enough of any of them. And that's a national issue as well as a local issue. And of course, that gets us into immigration issues, but you've had that discussion already. So, and then the fourth priority that we came up with is environmental conditions that affect health. And the thing that you notice over time is that everything's interrelated. All of this knits up together. So those were our four basic priorities. And I have given you in the materials a list of the specific healthcare bills that came through my committee, and I also gave you a list of the ones that came through Children and Family Law, so that you have all of those and you have the details of those, and those are available to you. So if there's something that you want to understand more about and haven't we haven't gotten to, please go there. And if you've got questions, my contact information and Mike's contact information is at the bottom there. So that's where we started out. But of course, then COVID happened, and that kind of changed everything and affected everything. And one of the things I want to make very clear to people is that although we were on hiatus for most of this last 3 or 4 months, we weren't not doing anything. And one of the things that we were doing an awful lot of was constituent services, and a lot of them had to do with healthcare, testing, personal protective equipment, all of that, and just connecting constituents, all our constituents, to what they needed and help. That ranged from helping people who had never in their entire lives applied for unemployment and didn't think they'd ever have to finding the ladies who were doing, and gentlemen as well, I shouldn't confine that to ladies, who were making masks and passing out masks for all the places that didn't have any masks at all. So there we were fighting a global pandemic in 2020 with 1918 technology, which is always kind of an interesting place to be. With the COVID virus came some real different perspectives on healthcare. And one of the biggest advances, we had been working on some telehealth issues in the committee, but because of COVID, of course, everybody switched to telehealth to do everything immediately. And so one of the legislative things we've done is incorporate a lot of those changes into law. So when the state of emergency goes away, we can continue to provide health care that way. And I know Mike Padmore is going to speak more about that. The interesting thing is that some of the things that came out of telehealth are really actually easier and better and allow far more access than before. So that was kind of interesting. Our real focus this last term was on mental health and addiction and recovery. And to do that, we actually divided the Health and Human Services Committee down into 2 different divisions. One focused entirely on mental health, addiction, and recovery, and the other division focused entirely on everything else. And I thought that that was going to be kind of a nightmare. But as it turned out, that worked out really well. And we have a number of people with a great deal of expertise on both sides. And splitting the committee meant that we could get a lot more work done simultaneously. So when we got back together for executive sessions, the executive sessions where you vote on things went a lot easier. And on that side of things, we passed, for example, an interstate compact that allows psychologists to practice across state lines. We did a lot of sort of micro stuff, like fixing really complicated spend down rules in Medicaid. But the result of fixing those spend down rules was that our mental health centers will get significant amount more funding from Medicaid. So that will allow them to provide more services. We had the endless adjustments to our therapeutic cannabis statutes. And what the committee focused on in that respect was trying to find the best available medical evidence for whatever new condition or service was asked to be included, and to make decisions based on the best medical evidence available at the moment. And that's an ever-changing thing. And of course, what we really need is to be able to do more actual medical studies, but the federal government isn't really into that at the moment. I want to touch just briefly on the child protection issue because that's out of a different committee, but we have had huge issues in DCYF, the Division of Children, Youth, and Families, going back 5 years and more than that. And in the last 4 to 5 years, we've made a real effort at turning that ship around, and we have brought caseloads for caseworkers down from being in the range of 90 cases per caseworker down to the high teens maybe now. And so we brought a lot more caseworkers online. There's been a lot of restructuring. And then the other thing that we were getting back to, and I hope we can continue in the light of the financial crisis that's coming down the road, is to continue voluntary services before a family is so in trouble that they need to be in the DCYF process. If we can help families with whatever crisis they're facing before they need state intervention, that's better for the family, that's better for the kids, and it's certainly better for the state budget as well. So there's been a great deal of work in that department. The other bill I just wanted to talk about a little bit, and I'm over the time I agreed with Mike, but I'm not much over, is we had a bill in our committee about protective orders for vulnerable adults, modeled on our protective orders for domestic relations. And we've tried in 2 years in a row to get that through the House. And after an initial try, it came out of my committee 20-0 because we, instead of allowing the police to take guns away from people the minute that they had an order filed, which is really important in the domestic relations context, but somewhat less important when a vulnerable adult is simply being robbed and not actually physically threatened. We changed that, and we got the whole committee to agree that if somebody had actually threatened a vulnerable adult, that you could take the guns away. Well, of course, you know, this was all, it's a gun bill, it's a gun bill. We can't have a gun bill because guns are going to be taken away from people. I happen to think that if they're threatening elders, they ought to be taken away, but that's silly me. So that one has had 2 rounds, and, you know, it's a matter of some sadness for me that our colleagues and partners in the domestic violence field have had concerns that I don't think are necessarily fit with this. But they're concerned that the existence of this kind of bill will provide confusion and therefore leave some domestic relations folks unprotected because they'll get the wrong kind of order. And I think that that's a long shot. And, you know, their argument was, well, if one woman gets battered because we've done it wrong, that's too many. And my argument is, yes, but we have a ton of elderly folks out there who are being either robbed or, you know, manipulated by family members and others. And we could get an order to stop that really quickly, but we can't. And it's given the governor some cover. The governor doesn't like it because he thinks it's a gun bill, whether the guns are in it or not. But it's given him some cover. And so he will say things in his veto messages like, well, this doesn't provide for the protection of the children. Well, first of all, these are elderly folks, and mostly they don't have young children. Secondly, there are 2 different kinds of orders that already protect young children. If you're in a divorce situation, you can get a court order through the family court. And if there's a child who is abused or neglected for any reason, you can go to court and get DCYF involved in protecting that child. So there are all these red herrings that are out there. So that's my unfinished business for next term if I'm back. And with that, I have probably already blathered on way too long. So I'm going to turn it over to Mike for his portion so that we will get to your questions.
Cool. Thanks, Lucy. And you definitely didn't go too long, so no worries.
Well, we said 10 minutes, so
it
was
okay.
longer than that.
Well, thank you. First, just thank you for joining us tonight. Excited to be here and have the opportunity to do this. From what Rob told me, it seems like a lot of the folks that are on the phone are candidates for office, which makes me very excited because through some of the other jobs I've done in the past, have worked a lot with candidates and just love working with you all. Appreciate you all taking the time to run for office and take on that responsibility of being either a state House representative or a state senator. Incredible amount of work, and really appreciate that sacrifice. So what I'll do is what I want to kind of touch on is when I initially talked with Rob about this, it sounded like what he really wanted to do is kind of hear about what happened, what's happening in healthcare in New Hampshire, over the last couple of years, and then maybe be able to frame that in a way that will give you guys some good information for the folks that are running for office. So I'm going to try to do that a little bit. Lucy touched on telehealth, which I'll try to expand on that a little bit because we were, in my role, I'm the director of Advocacy for the New Hampshire Medical Society, and we were pretty heavily involved when COVID happened, and honestly, there was actually a bill in regard to telehealth. There were actually two bills that were introduced at the beginning of the session anyway, so way before COVID. So this was really something that legislators and folks in healthcare have been really looking to expand telehealth for at least the last few years with the just the expansion in technology that we really have access to now. And then with COVID hitting, it really just accelerated that entire process by like 1,000%, which I think we're really learning is probably a very good thing. If there are any good things that have come out of this, I think telehealth is something that we're finding we're getting some great results. So I'll start with really why did we need this? So the main issue really was patients were still going to get sick, whether it was COVID or whether it was just the common cold or whatever it might be. Patients were still going to get sick when COVID hit. So they needed to be able to access their primary care provider or whoever that PCP is, and they couldn't go into that office setting. In some cases, they couldn't go into the office setting, and then certainly most folks wouldn't want to go into a hospital setting during a pandemic. So so that immediately created a need to try to figure out how do we still serve patients in this time when patients can't go physically see their providers. And then the other piece of this too was, as many of you know, a number of the health systems around the country, another example being Italy, outside of the country, is the real danger was if our health system got overloaded. If we hit a surge and then all of a sudden the actual capacity within the healthcare system just couldn't handle that volume. So telehealth was a really good asset for taking a lot of the strain off of that health system. So what exactly happened? So what we did is we basically relaxed some of the different regulations around telehealth that there are currently. One was just simply that patients could be seen from home. That was actually something you couldn't do before. So you could physically take a phone call, a FaceTime call, or just an audio only call from your primary care provider and actually have that visit over the phone. The other piece that was very important was actually leveling off reimbursement levels for in-person visits. Prior to this emergency order and then the actual HB 623, which was the actual bill that was signed into law that essentially carried over many of those things from the emergency order, it leveled off those reimbursement rates so that providers could financially stay afloat and still continue to see those patients at that same level. And then the other piece of it, which was really important, and something that's specific to New Hampshire, is to make sure that audio only calls were covered by this. In many cases, prior to this legislation, audio only telehealth visits were reimbursed at an even smaller fraction, and in some cases weren't reimbursed at all. So this actually makes audio only fully reimbursed to that in-person level as well. And that's important because, as many of you know, we have parts around the state that just don't have access maybe to that, to good broadband internet in the North Country, certainly out in maybe the Upper Valley, but really that's across the entire state in different pockets where we have challenges with some of that. So that was a real important piece of this that we really wanted to make sure got carried over. As far as what happened, so Lucy had mentioned that the results of this, we've gotten a lot of really great feedback, and that's not just from our providers, but really from patients. I think we're seeing many of our providers switching over a lot of their systems to a telehealth model, and some maybe not as much as it was during the the beginning stages of the pandemic. Some of them are kind of shifting back now to a little bit more of in-person visits, but we certainly are seeing an increase in volume on telehealth and getting some good feedback from folks that are liking that model. Patients, I think specifically, I've heard a lot of really great feedback from folks in the psychiatric community, finding that their patients are just much more comfortable. Being able to take that, have that visit just from your home is a much more comfortable setting than maybe having to go to one of these different facilities that you had to before. Another piece that I've heard mentioned in the whole area of medicine in regard to telemedicine is, if someone misses an appointment, you can simply, that PCP can just call that patient, and there's kind of just a little bit of a higher level of accountability, and just making it so much easier for that patient and their PCP just to be in contact with one another. And I have a note on here about rural providers. Specifically, I think rural providers have been really, really pleased with how this has worked out. And then I do want to just make a note of saying sort of where do we go from here too. So in the law HB 1623 that was passed, it does set up a study commission. And what that commission is set to do is to essentially study the impact of how this is impacting our health systems, healthcare costs, what is the impact of this telehealth law. So that's something that we'll continue to see. But I certainly do think, just based on the feedback we've gotten so far, is that I don't think telehealth is going anywhere. I think this is something that is going to continue in many ways to evolve, especially as technology continues to improve, and hopefully, we get to a place where this is really a real asset and a great tool for a lot of our providers for just being able to provide as much access to their patients as possible. So, and then obviously we're going to get to questions later. So if anyone has questions about that, please. A couple other issues I do want to mention. Prior authorization is something that we worked on this year, and it's something we'll continue to work on. And prior authorization, is essentially insurance carriers being able to deny certain procedures and medications, so reimbursements and coverage for patients. And what that does is it really, what we basically termed it as, it's a behavior modification. It's these insurance carriers really setting up barriers for providers where they know that they can't. They know that if they want to prescribe a certain medication or a certain procedure, that it's automatically going to get denied by a carrier. And what that does is then it all of a sudden creates a whole set of workload for either a whole billing department, or in many cases really for that provider. Many of the physicians that we work with spend hours and hours of their time on the phone talking with insurance companies, and essentially fighting for their patients and saying, I think that this patient needs this medication. This is why I'm prescribing this. Why are you denying this? And what that's really led to, it's led to physician burnout. We hear about this all the time, and I know we've got a couple of physicians on the call right now who can certainly talk about this better than I can. But the stress of that is immense. And the thing I always hear is, physicians and really all medical providers, they get into medicine because they want to treat patients. And I think what we're finding is that prior authorization is sort of setting up a system where, physicians and other medical providers are spending maybe 50% of their time with their patients, but then they have to spend another 50% of their time fighting insurance companies. And it just creates this horrible, horrible system. So that's something that when you hear about prior authorization, and hopefully you all be elected to the legislature, but we're going to continue to try to limit that as much as possible. So that we can kind of allow for patients to be able to get their medications, get their procedures when they need them, and not have to kind of create all those different barriers that the carriers will put up. Then a couple other issues that I just want to kind of touch on briefly, some things that happened in the last couple of years. We worked pretty heavily on a campaign with this coalition called Tobacco Free New Hampshire. It's a bunch of different stakeholders, all working on different issues related to tobacco products. But specifically, we were really working on e-cigarettes, most recently in vaping. And the big thing we really needed to do was make sure that e-cigarettes were actually classified under the tobacco statute, which they weren't previously. And fortunately, we were able to pass a law I think it was in the 2019 session, that actually classified e-cigarettes under that tobacco statute. And the important thing is that then it allowed us to just have a higher level of regulation around e-cigarettes, which before there just was very, very little regulation around those certain products. And then from there, this past session, we worked on a tobacco 21 law. And what that is essentially raising the age to purchase tobacco products. And remember, that's tobacco products, traditional ones, cigarettes, chewing tobacco, but then now classifying, because they're in the tobacco statute, e-cigarette products. And the real important reason why we did that, and this has been hit me a little bit more close to home recently, because I'm a JV coach at Central High School in Manchester, and I would just hear horror stories from the kids on my team telling me about how, you know, there's no smoking in the bathroom anymore. Well, there's probably that too, but kids will literally smoke they'll vape in classrooms. And, you know, Tobacco 21 is not going to stop that, but what it's going to do is it's going to make it just that much harder for those products just to get into the schools. Again, we're not pretending that this is going to stop underage smoking, but what it does is it's going to just make it that much harder. So that was something that was passed this year, and we're real excited about that, and we're going to probably continue to work on other regulations that we can pass. One of the things that wasn't passed this year, which we'll probably work on next year, is a law around banning flavors for these products. I did see a question about paid family medical leave in there, and I was planning to talk about paid leave anyway, so maybe I'll just sort of hit that, and then Lucy, if you have anything to add on this too, please jump in. But I think the question was around just the differences between, and I'm going to call them, I think it was SB1, and then, oh, forgive me, I'm forgetting the actual number of the House bill, but I think it was Mary Jane Wallner's bill this year that was vetoed. So I'll start with just by saying, because I think the thing that's in the news most often is that this is an income tax. When you hear Governor Sununu and Americans for Prosperity and all these different organizations talking about how, you know, we need to veto this because it's an income tax. It is not an income tax. I will be very clear in that. It's not income tax. It is a payroll tax for employers. So it is not a direct income tax to individuals. So just to be clear on that, if someone asks you that, you can be very clear in saying it is not an income tax. The way that I'm going to call it the Feltus and Mary Jane Wallner program, just for ease of understanding. What it is, payroll tax for employees covers all employees in the state. There is no opt-in, opt-out. It is all employees in the state. And it would be ran through the Department of Employment Security. They already run. And the reason why this is a little bit close to home is the job I had before I worked for the Medical Society. I was actually working on this for about 2 years. So this is something that I'm hoping we'll continue to work on over the course of the next couple of years. But we worked pretty closely with the Department of Employment Security to make sure that they were an agency that felt that they could handle that program. And they gave us an assurance in saying, you know, they already run the unemployment benefit here in New Hampshire, the insurance program. And this program would run essentially very similar to that, where folks would pay into this program, and then you would then have a 60% wage replacement if you needed to have a claim taken. And I think that would cover 12 weeks of time. The Sununu option was a really completely private option. And what it would do is it would essentially go to bid for private insurance companies to bid on and say, hey, you know, this is what we think we can do this program for. This is how we would want to run it. And the danger with that, and I'll be very frank, at the Medical Society, we opposed that program, the Sununu program, and we were supportive of the two bills from Mary Jane Wallner and from Dan Feltus. And the reason why is because the Sununu program, what it does, since it goes to bid with a private carrier, private companies need to make a profit. They're not going to just do this for free. And I always like to say this before too. If it was beneficial for a private insurance company to have a paid leave program or paid leave insurance, they would already have that product. So there's a reason why they don't have that. So what it would do is it would essentially allow for private companies to kind of set the rules on that. And our argument was basically, well, if a private company is going to do that, you know, they're going to do one of two things. It's either going to be too expensive for the people who need it, or they're going to cut benefits, and it's really just not going to be worth it for the folks that do need it. So that's sort of it in a nutshell. But what I will say for the person who asked that question, I'll just say the folks over at the Campaign for a Family-Friendly Economy, their executive director, Amanda Sears, she would be a great person for you to speak speak with. And I'm happy if you want to reach out to me afterwards, or anyone else that has questions about that, I'm happy to connect you directly with Amanda, because I'm sure she can tell you so much more about that, and kind of go into much more detail. And I think with that, I think I'll stop, because I think I'm also kind of getting close to my time also. And then there's probably some other things in here, but why don't we just go to questions maybe, and we'll kind of go from there.
And I don't
Lucy,
have
do you have anything you want to say about paid leave?
No, I think that pretty much covered the points that I wanted to make. So thank you very much for that rundown on it.
I'd just like to ask a general question, which is, I think, going to face a lot of these folks as they talk to their constituents, which is, how would you grade Sununu's response to the pandemic in New Hampshire? And what good talking points and what ammunition might you give the people on this call? Because I think that's one of the toughest issues.
That's a great
Democrats.
question. And I will say that there are a lot of things that I think he has done well, or as well as you can do when faced with a really horrendous situation. And the numbers bear that out. We're second only to Vermont in our current infection rates. So depending on what monitors you're looking at, and I look at a whole bunch of them every day and keep charts now because I can't remember what happened yesterday. But we're in a really good place. I mean, hospitalizations are way down. Of course, we're also beginning to get the little niggles, particularly in my county, that we may be going up again. And you've got the college student issue and all of that. So day to day, the picture changes, and our numbers are low enough so that a very few numbers changes are, a very few number of cases, and we're 50% higher than we were last week. So that's to be borne in mind. That having been said, there are several things. First of all, I think masks should be mandatory, and I think we ought to be enforcing that. And the House Democrats have written that to the governor. Many, many people have made that point in many, many ways, and he has refused to do that. The second point I will make is that he's very, very good at making everybody feel like he's on their side. So if you watch his press conferences, and he has a minimum of 2 a week and sometimes more at 3 o'clock in the afternoon on WMUR, he will say, oh, of course, we want absolutely everybody to wear masks. Of course, we're not going to actually issue any penalties or anything we don't want to have penalties if they're not wearing masks. So if you're in favor of masks, oh, he's spoken to your side of the question. If you're not in favor of masks, he's spoken to your side of the question, and he's got everybody's vote. And he does that on every single issue, not just healthcare. I think that the second thing I am very concerned about is that he was given $1.25 billion, which is about 1/10 of the state budget. And he has been dispersing it. And yes, he has advisory groups, but there are no controls over his absolute authority over that money. And sometimes he listens to the advisory groups and sometimes he doesn't. And, there are a lot of winners and losers, and, figuring out where it's gone and who has won and who has lost is a real issue. I think the whole cowboy mentality with respect to supplies of everything from testing kits to PPE to everything else, it's great that Dean Komen can go and get a plane load of stuff and bring it here. But then, some people win and some people lose in that. And I think this is more of a national comment than a state comment. I think we ought to be on a wartime economy, and I think we ought to have a certain amount of rationing so that we have national priorities for where things go. And the one I think about a lot, because I actually in my last life had nothing to do with, I'm not a healthcare professional, I just now play one at the head of the table. I was an elder law attorney, and it drives me nuts that our nursing homes were kind of the end of the line for the PPE, and that's why we had outbreaks. And it's no joy to say that if you look at our mortality rate, over 80% of the people who have died in New Hampshire are people who came from a congregate living setting. And that means that we have twice as many people who died from, relatively speaking, from congregate living settings than the nearest next state. I mean, most states are running around 40%. So either we have an extraordinarily healthy general population, or we should have been doing more for our nursing home patients, and we should have been doing it earlier. And I say that with enormous respect to the many nursing homes that have never had a single case, because many of them have done an incredible amount of work. But in my local county nursing home, they were putting out calls not only for people to make masks, but for people to does anybody have lab coats that they can donate that we can wash and reuse as protective garments? How about large size men's shirts that we can take the collars and the cuffs off of and make reversible button up the back protective garments? I mean, people were literally sewing for the nursing homes and sewing for the health agencies. And these are the people who are dealing with our most medically vulnerable people. So in that respect, I don't think he's done particularly well. So I'll stop there, and because I can really rant on that. I'm sorry.
Oh, no, it's worth that. It deserves that. Catherine Haraki, sorry, Catherine, if I'm not saying that correctly, but she makes the good point, I think, that, we are between Quebec, Massachusetts, Maine, and Vermont, which are states that are doing quite a bit more to enforce restrictions, and that we're benefiting greatly from that.
Absolutely. Absolutely. We're next to a state. Massachusetts values education above everything. We are benefiting. We are alive because we are next to that state. With the attitude of the people in New Hampshire right now, if we were next to Florida or South Carolina, we would have much different numbers. So this is my opinion. Yeah. And I'm very glad that we are where we are. We're very lucky.
Yeah, I think it's an important point to keep in mind. So thank you for making that. Can I just go back for one moment to paid family leave? There was a question, and I think it's an important one for us to understand from Andrew Manival about Senator Gaida has said that there is no actuarial study on the likely cost of paid family medical leave. Could either of you speak to that? Because my understanding is that there were multiple actuarial studies, and that we could also look to the experience in Washington State for
I think you're right on that. And you plans always differ, so an actuarial study is always an assumption, but I'll let Mike, if he has anything extra to add on that.
Yeah, the only thing I will add is that that was sort of used as an excuse by the Republicans to really just kind of to try and kill this thing, to say, we can't guarantee that this will be solved. Well, it's pretty much impossible to do that. No study could do that. There's only so much guarantee you can sort of do in some of these different programs. So could we use all these different models to really try to get as best of an estimate as we possibly could for how much these different programs would cost? Yes. We've had so many different studies that looked into the numbers to make sure that UNH did an analysis for us, so that we could go over the costs of this, and we could say, okay, this is how much money will be in the fund. This is if we have this many claims. So we tried to do as best we possibly could to say, this is how we can have a solvent program. Again, they use that as more of an excuse to say, oh, well, we can't guarantee that this will be solvent. Well, it's like, well, it's almost impossible to do that in many cases for really any sort of these programs. So we really had to try and do the best that we could with the way that the program was set up. So hopefully that answers your question.
That's helpful.
Uh,
Thank you.
Mike, also a couple of questions. I see one here from Leslie Bergman about opioids and and substance abuse in the state. Can you give a kind of quick overview of where we are, and are we making progress or going backwards, or how are we doing?
Well, I don't know. That's probably a large question, and maybe I would defer maybe to Lucy as well and see if she has a little bit more insight into that. I think that what I would say is that over the last few years, it's been a priority, and maybe hasn't been a priority in just years past for different legislatures. That we've invested more money in it, and I think one of the things that we are trying to do, that I'll highlight, is that much of this is a workforce issue too. Is making sure that we have enough providers in the state to care for folks. And I think that's something that has been a stark change, where we really tried to invest maybe some money in those different areas. But with that, I'll kind of stop, and I'll see if Lucy has some other things to add.
Well, I wish we were actually having this next week, because the Health and Human Services Oversight Committee, which is where I get all of my statistics, hasn't met for 4 months, but it's meeting tomorrow. So I may know more then. I'll say a couple of things about the opioid crisis, one of which is that it's been very interesting to see sort of the numbers that we know something about. For example, at the beginning of the COVID crisis, overdoses and opioid deaths went way down, and I would have thought they would go way up, because I would think everybody was stressed to the max, but what apparently didn't play out that way. And I don't think anybody really has a huge grasp on that. I will say that one of the things I want to share with you that has happened that I think has the potential to help a lot is the Doorways program. And I have a huge amount of problem with how it was set up and how it was run out and how long it took. But the basic concept is, it's an extension of the concepts that you have with safe stations. Somebody is ready to get help, get them a person who can tell them where to go and what to do right now and connect them up when they're ready. And the Doorways program is set up to do that. And the intake is now sort of set up with mental health centers and counselors, to the extent that we have enough, to get people into treatment. What they haven't done is they've done really poor communication on the program. And now they just say, well, call 211. And if you know about a Doorways program, you can Google it, but if you don't know about it, you might not. And I was shocked when I had a communication from a woman who was searching for help for a family member and had gotten completely stuck because the one program that she had found would not take the family member for 14 days because he had been to Massachusetts at the height of the Massachusetts outbreak, and they wouldn't take him for 14 days because of that. I said, I'm sure you've heard about this program. And she wrote back and said the day later and said, no, that was so helpful. And she had been literally talking to healthcare providers and other people for weeks trying to find help for her family member. And the program actually hooked him up with somebody who got him through the crisis part so he could get to his residential program. So there is some help out there that isn't being very well publicized, but if you either Google the Doorways program, and for the first few months when it was set up, when you Googled the Doorways program and then you checked Cheshire County, which is where I lived, you got the street address of Cheshire Medical Center or local hospital, which is not helpful if you do not have a car. and it didn't even give a telephone number of where to call so you could find out how to get there. That's been fixed with both with the links, and you can go to 211, which is sort of the general I need help with something line. The other thing is that Waypoint, which used to be Children and Family Services, has set up something called the Warm Line, which is not, I think, a really helpful name, but again, it's a resource for people before they get completely into crisis mode. So you call and they give you an hour's worth of advice on who to call next and where to go and what questions to ask and what services might be out there, again, before you get into crisis. So that's another resource that's out there. But there's always a lot more to do. And on the one hand, we have a crisis of not being willing to pay for it on the one hand. So we don't right now have the income coming in, and we will have less income coming in next year, of course, as you heard in the last session. And the other crisis is, even if we were willing to pay for it, we have a real crisis in medical providers across the board. And people are working on that. But
so there are a couple follow-up questions on telehealth, because it's, it is a new path in medicine. And so from Jane Van Zandt and also from Laura Vincent, concerns about what protections can be put in place for people who actually need in person, and also how do we square the idea that you don't get that same level of service from being with your provider who is doing things like listening to your heart and checking you physically.
Well, from the non-medical perspective and the chair of Health, Human Services and Elderly Affairs perspective, that's going to be the next challenge, is ensuring that what we're using telehealth for are the things that it really does better. Like, I had an attached tick recently. I didn't have to go and show anybody where the tick had been before I had the discussion about whether I was going to have antibiotics or not. And I said, I don't care that I was only attached 8 hours or less. I want the antibiotics right now. And they did. And that could all be done by telephone now. And that's an incredibly useful way of doing things, because it ties up everybody, it frees up everybody for more urgent in-person needs. But I do think that that's going to be the next battle line. And that's, I also need to, oh God, how can I get this to go there? My apologies. I think that's going to be the reason that telehealth has moved so slowly, is that fear has been out there. And I think the next challenge is going to be to figure out where and in what instances it's actually helpful and an extra benefit. And again, one of the real major benefits that it does provide is access to mental health care in places where it's not available, and in situations where some people may actually feel more comfortable with it. So that's going to be a huge learning curve, and it's something that all of us need to keep firmly in our minds going forward, because of course I mean, my other example is that I did just get told that my dermatologist is only doing telehealth unless you have a history of melanoma. And if I have any spots I'm concerned about, I can send her a picture. Well, my whole body, I am 68 years old and I've spent a lot of time in the sun. I'm nothing but spots. And half of them I can't see because I live alone and they're behind me. So that's one of those cases where it would be a lot more helpful for me to go in and have her spend 15 minutes looking at things that she knows aren't any issue. So that is a big thing that's going to have to be sorted out.
Mike, do you have any comments about telemedicine to these questions?
Yeah, honestly, Lucy nailed it. That's exactly right. I mean, the process of how bills and legislation are made all of this will be sort of worked out through the different interests of how do we best serve patients. And that was really one of the hesitations. Lucy really nailed it. That was really what was kind of holding a lot of this up. There was a fear or there was a concern of really wanting to make sure if we're going to expand telehealth, let's make sure that we're doing it in the right way. And I can certainly say we've got a number of members that were really concerned about that too. We had testified and they had testified to that, during a lot of these processes of working some of these bills out. So yeah, I think that's right.
Okay, let me ask one last question, and Mike, you're not allowed to answer this one, but it's from our friend Dennis Jakubowski, which he'll ask,
I can answer
if you had one thing to say to a voter to dissuade them from voting for Sununu, what would that be?
Oh, heck.
I've got one.
Go for it,
Are
Mike.
you allowed to do
Paid
that?
family medical leave.
Oh,
Yeah.
Paid family medical leave. And what I'll say,
if you look at the materials that I submitted, and my understanding is they're going to be emailed out and then they will be up on the website. The vetoes that he has done, and I think there's 79 of them, he has stood in the way of paid family medical leave. He stood in the way if you're in any way interested in gun control and gun safety and gun violence protection. That's item number 2. And that's a major health issue as well as everything else. The protection of vulnerable adults. I ought to have a whole list right at my tongue, but there's so many that the waves of vetoes come in and then they wash right out again. Even things as simple as, and actually I think there was a question earlier with this about Medicaid. For example, complete removal of the work requirement for the expanded Medicaid program. We negotiated that down a bit, and we removed it to begin with, and then we had to reauthorize the program, and the work requirements had to be in there or the Republicans wouldn't have voted for the program, and we really needed 50,000 people not to lose their health care. And then there was the court cases in other places that said these requirements are not legal. And Sununu and others got scared. And so we actually managed to pass a bill that allowed them to waive the work requirement, all the work requirements going forward for a while. And then our court case said you can't do it that way. But I'd love to get rid of that once and for all, and to make sure that we're not running up against deadlines. And as long as we're getting towards the end, I'd just like to wave to and acknowledge various of the members of my committee. I see Dick Osborne and Gary Woods there, and they've been working on this stuff, and there may be others that I can't see. I know Joe Shapiro was on the last call, but nobody has ever had a better committee to work with than I have had this last term. And we did get a lot of stuff done, and a lot of the stuff that was bipartisan and came out of the committee, either like the vulnerable adult bill that we had all of us on board. 6 of the Republicans bailed before they had to vote for it on the House floor, where the votes get recorded so people can see them. And then the governor vetoed it. Now, I had really, really conservative people that had signed on to that. And so, and there were any number of other bills that were very bipartisan that he vetoed. So look at a list of his vetoes. And I guess that means that the short answer is look at the governor's vetoes, and that's why you shouldn't vote for Sununu.
Okay, everybody, we got a busy week next week. We have 3 Zooms led off by Karen and Louise talking about how the House is operated during COVID, which I think will be a very interesting thing, and what's going to happen to it if the COVID virus is still around come January. But thank you all very much, Lucy and Mike, for being with us. And We'll see you all next week, and I will post Lucy's outline tomorrow morning, and we'll get the recordings up on the site as soon as we can figure out how to do that. But thank you all. We'll see you on
Thank you
Tuesday.
all
Good
again
luck
for
in the
all
election
work
this
you're
year, folks.
doing. I really appreciate it. It's amazing.
Yeah. Thanks, everybody.
Thank you.
Thank you, everyone. Good night.
Good night.